called Balancing the Immune Response. Regulatory T cell determine the course of acute and chronic pancreatitis. And this will be presented by Dr. Matthias Sendler from the University Medicine of Greifswald. Thank you so much for joining us today.
Thank you very much for this kind introduction.
It's actually good.
Okay. So, thank you very much for this kind introduction. First, I want to introduce a little bit regulatory T cells. The title mentioned that we were interested in the function of regulatory T cells during acute as well as chronic pancreatitis. Regulatory T cells belongs to the adaptive immune system. These are CD4 positive T cells, which are characterized by the expression of the transcription factor FOXP3 and by the expression of the surface receptor, the IL-2 receptor CD25. And the function of regulatory T cells is that are suppressive cells, which are able to suppress the immune response, especially the T cell immune response, by the release of suppressive cytokines like IL-35 or IL-10. And we were interested in the function of regulatory T cells by suppressing immune response during acute and chronic pancreatitis. First of all, we start with the model Julia introduced 2 days before by partial duct ligation, because this is a more severe model of acute pancreatitis. And we see it has a much higher T cell activation. So we think if we see effects, we see it mostly here. And what we done, we ligated pancreatic duct. It develops a very necrotic pancreatitis over 3 days. And we isolated T cells from spleen to look if we have an increase of regulatory T cells. And what you see here, in contrast to untreated mice or sham-operated mice, we see a significant increase of regulatory T cells during acute pancreatitis. And we were not only interested if the amount of regulatory T cells increased, also if their function is increased. So we do some functional assays, suppression assays. We isolate regulatory T cells on the one hand from animals which suffer of these type of pancreatitis, and control animals, co-incubate them with normal T cells, and see that the T cells of the animals which have acute pancreatitis have a higher suppressive capacity in compared to control animals. We also were interested if we see regulatory T cells in the pancreas, but during acute pancreatitis, I can say we didn't see so much T cell infiltration in the pancreas after 3 days. So we were interested in a different organ, which is also near the inflamed pancreas, and this is the duodenum. We do exactly the same experiment. We isolated T cells from the duodenum, and we see also in acute pancreatitis mice compared to untreated mice or sham-operated mice, we see an increase of regulatory T cells in the duodenum. In contrast to regulatory T cells, other T cell populations, especially intraepithelial T cells, which are here shown in red fluorescence, which are marked by CD8, or T cells in the lamina propria, here is shown as blue cells, which are normally marked by CD3 or CD4, they get reduced in contrast to FOXP3 expressing regulatory T cells, which are dramatically increased. So, and to study now the role of the regulatory T cells, we want to do functional experiments in animals where we can deplete regulatory T cells. Therefore, you use direct mice, which express the regulatory, where regulatory T cells express under the control of FOXP3, the diphtheria toxin receptor. So we can easily deplete regulatory T cells by the injection of diphtheria toxin. This is what we've done in the animals which suffer from pancreatitis. And here you see in spleen, we have nearly a complete reduction of regulatory T cells. Furthermore, we were interested, how does T cells behave in the intestinal system? And what we do again is we stain the intestinal system, and we see a dramatic reduction of T cells in the animals which receive PBS. In contrast, animals which receive diphtheria toxin and have no regulatory T cells, we see a normal behavior of T cells in the gut system. And what we also see very clearly is that Th17 cells, which are prominent in the intestine, are stabilized in the animals with a lack of regulatory T cells. And what we also know is that Th17 T cell response is responsible for the homeostasis of the microbiome in the gut system. So we were interested, did we see changes in the microbiome in the gut system? Because it's known that during acute pancreatitis or severe acute pancreatitis, the microbiome of the gut can infect the pancreatic necrosis, which leads to a more severe phenotype of pancreatitis. And therefore, we isolate microbiome samples from the duodenum of the mice, and we see here marked in red, the animals with acute pancreatitis, which are depleted for regulatory T cells, have a much more stable microbiome compared to animals which have only acute pancreatitis receive PBS and have a normal Treg population. And you see these are the animals which have acute pancreatitis and treated with PBS. They have a less diversity and a less richness of the microbiome, and especially pathogenic microbiota like Escherichia coli in this case are increased in animals which acute pancreatitis and are decreased in the animals which are depleted for regulatory T cells. And therefore we ask us now, did this have consequences for the acute pancreatitis and the severity? And we look in the pancreas of these mice, and first we check if we have infected necrosis in the wild type mice, and we see we have much more or significant more affected necrosis animals under the PBS treatment than under the diphtheria treatment. And this means that regulatory T cells stabilize the gut barrier function and therefore prevent or allows the migration of microbiota into the pancreas. And also the disease severity marked on the histology score as well as on serum amylase is decreased in animals which have no regulatory T cells anymore. What we know from the clinic is that a lot of patients with acute pancreatitis develop chronic pancreatitis. So we were also interested in a kind of chronic pancreatitis. What is the role about regulatory T cells? We use a mouse model where we inject cerulean repetitively over 4 weeks, and we want to investigate how pancreatic tissue changes. First of all, we look in spleen if the regulatory T cells are increased in the mice model, and we see also in spleen we have a slight increase of regulatory as well as of Th2 T cells. And in contrast to acute pancreatitis and chronic pancreatitis, we see a prominent infiltrate of T cells in the chronic inflamed organ. And also, if we look to these T cells, we see there's a high abundance of regulatory T cells within the inflamed pancreas. It's much higher compared to Th2 cells, Th1 cells, or Th17 cells. So, and now we use exactly the same model of the direct mice to deplete regulatory T cells to look what is the function of regulatory T cells during chronic pancreatitis in the pancreas. If we induce normal cerulean-induced chronic pancreatitis, and here you see some histologies of the PBS-treated group. And in contrast to the PBS-treated groups, which are depleted for regulatory T cells, we see a much higher amount of fibrosis. We see a much higher amount of CD206 positive M2 macrophages, which results also in higher amount in activity of pancreatic stellate cells and higher amount of fibrosis. And if we look also to some pancreas acinar cell markers, like for example, amylase or trypsin, we see compared to the wild type mice, the mice which have a lack of regulatory T cells have a very low amount of residual acinar cells, which leads also to a low amount of fecal elastase and results finally in a dramatic weight loss of these animals. To summarize now the role of regulatory T cells in acute and chronic pancreatitis, I can say regulatory T cells suppress Treg function in the development of acute as well as chronic pancreatitis and impacts disease severity in 2 different ways. On the one hand, we have a suppression of the Th17 response in the intestinal system, which allows at the end bacteria from the duodenum to colonize the intestinal barrier or to colonize the pancreatic necrosis. And this increases the severity of pancreatitis, whereas regulatory T cells in a chronic form of pancreatitis suppress an excessive Th2/M2 activation, and this prevents excessive fibrosis. So to conclude, regulatory T cells have 2 different roles in the diseases. In a chronic form of pancreatitis, they are necessary to prevent excessive fibrosis, whereas in a severe form of acute pancreatitis, they help bacteria to translocate into the pancreatic necrosis and induces an enormous cause. Thank you very much for your attention. This work is not done by me alone. Here are all the people who have helped me. Thank you very much.
So the paper is open for discussion. We have about 1 minute left. So if there's any burning questions, I'd like to know what's going to be the next step, because this is obviously fabulous work. How do we bring this forward to be able to apply this to our patient population?
The next step will be to look in the mechanism and how regulatory T cells act on other T cells. Maybe cytokines like IL-10 could be targeted on the one hand, but it shows it's very difficult because in a mild form of pancreatitis, regulatory T cells did not act so hard like in a severe form of pancreatitis where they prevent or where they support the development of CARs. And on the other hand, if you have patients with chronic pancreatitis, regulatory T cells to treat them is that you allow an excessive fibrosis development, which is also very critical.
Robert Sutton, Liverpool, just very briefly, because I know you're limited time. How many data do you have to support the idea that all of these processes are the same in humans?
So we know from patient data, we see that we have a high amount of regulatory T cells also in patients.
Where?
In the blood. We can only fax in the blood samples from spleen we did not get, and also from the intestine we do not have till now. And what we also see is that the same bacteria we find in murine necrosis, which grow up into a duodenum, are the same bacteria or the same taxa we could also identify in human pancreatic necrosis samples. So we think that the way how bacteria transmigrate into the pancreas is nearly the same in mice compared to men. But for sure, there are differences between animal and human.
Yeah, maybe needs to fill some data on those points.
All right, thank you so much.
Thank you.
Thank you very much. And our next paper will be elevated neutrophil gelatinase associated lipocalin as a biomarker of chronic pancreatitis, a PROCEED discovery cohort. This will be presented by Kristen Gumper-Fetus of the Ohio State University Wexner Medical Center. And I'll just note that Dr. Gumper-Fetus is recognized as a young investigator.
Thank you very much for that wonderful introduction, and thank you for coming here to hear my talk. As we've been discussing for the past several days, pancreatitis is an inflammatory disease that can be progressive from acute to recurring acute to chronic pancreatitis, and even a small portion progressing onto pancreatic cancer. So the clinical challenge that we've started discussing is that there's no biomarkers of chronic pancreatitis, aside from really expensive imaging or invasive testing, and that can only really detect severe or advanced disease. We've recently published a paper of a systematic look at the current state of biomarkers for chronic pancreatitis, and found that none of them have progressed past a preclinical exploratory phase using the probe strategy, which is a biomarker strategy that was developed for cancer biomarker research. Now, within this paper, we found that one of the proteins of about 81 different potential biomarkers, neutrophil gelatinase associated lipocalin, or NGAL, is a potential biomarker for chronic pancreatitis and is actually an interest in our research lab. So NGAL, also known as LCN2, its job is to bind hydrophobic ligands and has been identified as a potential biomarker for several pancreatic diseases, including PDAC, acute pancreatitis, diabetes, and even comparing chronic pancreatitis versus PDAC. This graphic here is just showing some of the variety of roles that NGAL can play in the cell, which includes iron and lipid binding transport and interacting with immune cells. So our hypothesis for our project was to determine whether NGAL, from ready available biofluids like blood, is a diagnostic biomarker for chronic pancreatitis. We started with a single center study at the Ohio State University, and we show that plasma NGAL can tell the difference between control, chronic pancreatitis, and pancreatic cancer. So the next thing we wanted to do is determine whether or not it's a good biomarker. So one of the things that we do statistically is create a receiver operator characteristic curve and then measure the area underneath that curve to visualize the trade-off between sensitivity and specificity for a given potential biomarker. So the higher an AUC is between 0.5 and 1 being the best, the better your biomarker may be. So when we looked at our single site data, we saw that chronic pancreatitis was somewhat acceptable for differentiating between control and chronic pancreatitis. However, I will mention that there was not a lot of samples in this study. And there were a lot of clinical characteristic differences. But we used this to move on and power a bigger, more controlled study for assessing the biomarker ability of NGAL. So just to show you this probe strategy, the first stage is preclinical large studies and then moving on to clinical validation. So before we can validate, we really wanted to make sure that we've crossed our I's and dotted our T's, if you will, for the preclinical exploratory study. And for that, PROCEED follows the probe design for biomarker development. So you've heard a little bit about PROCEED today from Dr. Darwin Conwell, as well as several others who have made use of this wonderful resource. And for our study, we aimed for having about 50 subjects per group. And we see that there is no difference between age and sex. However, there were differences on BMI, etiology, pancreatic deficiency, diabetes, and smoking, which are expected based on what we know about chronic pancreatitis. So what we see in this data cohort is that NGAL is elevated in subjects with CP compared to controls, AP, RAP, and in the plasma only. If we look at those AUCs, we see that this larger cohort, NGAL, can differentiate CP from all of the other groups, control, AP, RAP, and even abdominal pain. So because there were differences on different clinical characteristics, we then looked at NGAL across these different characteristics. So what I'm showing here first is the NGAL levels based on sex, with male on the left, female on the right. And what you can see is that although we can see that NGAL is differentiating between CP, AP, RAP, and control, it's not doing anything different between the sexes. And that was maintained across BMI, exocrine pancreatic deficiency, and smoking, where there was no differences between the groups, except for when we're comparing chronic pancreatitis to any of the other disease categories. The only difference that we did find based on a clinical characteristic was on diabetes, where plasma NGAL levels were higher in patients with diabetes and chronic pancreatitis compared to those without diabetes, but with chronic pancreatitis. Now, this was kind of interesting when we looked into the literature and saw that NGAL is elevated in patients with diabetes, diabetic nephropathy, diabetic neuropathy. So that suggests that NGAL may be somehow related to the biology of diabetes, but that's still unknown. So to further look at whether or not NGAL can be a biomarker of chronic pancreatitis, and we know that a single protein isn't going to be the answer for a biomarker, we decided to combine NGAL with clinical characteristics that were not comorbidities of chronic pancreatitis. So what I'm showing here is an ROC that was generated using NGAL, sex, age, BMI, and having ever smoked. And what we can see is the AUC has been drastically improved to 0.874 from 0.77. And this is maintained across pain, AP, and RAP. And the two factors that kept repeatedly coming up as statistically significant was BMI and smoking. So I then created another regression going back to the original OSU data. So just as a reminder, the ROC or the AUC was 0.653 just using NGAL. However, when we add BMI and having ever smoked to that regression, we're now improving the AUC to 0.806, which is a great improvement at differentiating between control and CP. So what that's suggesting to us is that blood NGAL could be a potential biomarker, especially when we consider additional clinical characteristics like BMI and smoking. Now, this is only half the story. What's really exciting is we went in and did CyTOF analysis to look at immune cells that are NGAL positive as well. And my co-fellow postdoc, Dr. Kaylin Chaser, had a poster on that yesterday, and she's here if you want to talk to her about that as well. So the next stage for this project is to move on to our phase 2, where we do a larger validation in a separate cohort using PROCEED, which has a completely separate validation cohort. And we look forward to validating NGAL as a biomarker for CP. I want to thank our lab, our collaborators at OSU, the members of the CPDPC, and all of the people who have donated samples to the PROCEED study. Thank you.
Very much. Is that open for questions?
Interesting talk. And so when you have the demographic characteristics in addition to the NGAL, I'm wondering what those receiver operator curves look like if you take NGAL out and you just use the demographic features, smoking, obesity, in your model.
Mhm.
Like what is the incremental increase to the demographic factors that NGAL provides?
Yeah, that's a really good question. I didn't actually do that question, but that's a really good point, and I'll make sure to look at that as soon as I can. Thank you.
Thank you. Please remember to introduce yourself
Oh, sorry.
for the questioners. Yeah.
Weisberg from Columbia.
Thank you.
Hi, Christine. Minoti Apte from Sydney. Very interesting presentation. So I was intrigued to find that you don't find any differences between acute pancreatitis and recurrent acute, but then there's a difference with chronic. So I was wondering, is this could be a marker of just chronic inflammation? And do you need to look at it and say rheumatoid arthritis or something like that, which may not be specific to chronic pancreatitis is what I mean.
Yeah, that's a really good question. So it is important to note that the PROCEED samples are collected 1 month after an acute attack, ruling out any acute injury because NGAL is an acute phase response protein. So it is up in acute diseases like acute kidney injury, and it's currently being detected as a biomarker in that disease. However, because this is 1 month later, we are really only looking at chronic disease. So I think that's a really good point to look at other inflammatory chronic diseases.
I just wanted to ask, we heard a very nice presentation earlier about some of the imaging findings
Yes.
related to progression of the T1 signal ratio, for example, within the same consortium. Is that something that you've been able to explore as far as making that correlation with some of those quantitative imaging findings?
Yeah, so I think that'd be a fantastic study and a fantastic next step as well.
Okay,
Thank
thank you
you.
very much.
Great. So our next poster to be presented is entitled "The Interaction of Pancreatic Stellate Cell and Macrophage May Exacerbate Alcoholic Chronic Pancreatitis." It's going to be presented by Dr. Zihong Zhu from University of New South Wales. And we want to acknowledge that Dr. Zhu is also a young investigator.
Thanks, Chair. Very kind introduction. And first of all, I would like to thank the APA meeting organizer gave me this opportunity to present our work. This is a HE stained chronic pancreatitis tissue showing the abundant fibrosis, which is known to be produced by pancreatic stellate cells. Alcohol abuse is the most common cause of chronic pancreatitis. With the most heavy drinkers also being heavy smokers. Epidemiological studies suggest that smoking accelerates the progression of alcoholic pancreatitis. However, the mechanisms mediating this are unknown. We hypothesize that alcohol and smoking activated pancreatic stellate cells interact with macrophages to potentiate pancreatic necroinflammation and fibrosis. The concept is showing on this slide. Which one is the later point? Sorry. Oh, because there's two different screens. Okay. We know that pancreatic stellate cells can be activated by the alcohol, smoke compounds, and inflammation mediators. Once activated, the stellate cells will produce growth factors and cytokines, which could form paracrine and autocrine loops, which perpetuating the activation of stellate cells, leading to the pancreatic fibrosis. Stellate cells can also produce interleukin-4 and 13, which can polarize macrophages into a M2 phenotype or a profibrogenic phenotype, and the macrophages can produce TGF beta and PDGF. These will act on stellate cells, forming a feed-forward loop. And we also know that M2 macrophages can increase the production of TIMPs, which thereby reduce the degradation of collagen and further promoting pancreatic fibrosis. So the first aim of our study is to assess the effect of alcohol, cigarette smoke exposure, and the endotoxin on inflammation and ER stress in a mouse model of alcoholic pancreatitis. There were 8 treatment groups, including control or alcohol diet feeding, cigarette smoke exposure, and LPS challenges as a single, dual, or triple combination. We measured the blood alcohol concentrations in alcohol-feeded mouse, and we found that the blood alcohol concentration was equivalent to moderate drinking in human. We also measured the nicotine metabolizer cotinine to assess the smoke exposure level, and the result had shown that the cotinine level was equivalent to heavy smoking in human. Therefore, our animal model closely simulates the human disease condition of alcoholic chronic pancreatitis. We have found in our model that the triple combination of alcohol, smoke, and LPS produced the most histology injury. For the interest of time, I will only showing you the macrophage data. We have found that it appears LPS driven the macrophage infiltrations in the pancreas. However, the important finding is that the alcohol and the smoking further increase the macrophage infiltration compared to LPS alone. We also found that alcohol and smoking increase the ER stress in our animal models. And when cells are under stress or toxin insult, the protein production, there will be misfolding of the protein, and which will accumulate in the ER lumen, causing the dilatation of ER lumen. And with the help of EM expert, now we can quantitate the dilatation of ER lumen. So as you can see, the bright color, which is showing the width of ER lumen on these images. So we measured 30 randomly selected images per sample, and the preliminary results had shown that the ER lumen was wider following the treatment of alcohol feeding or smoke exposure or LPS challenges. So in our animal model, we have found LPS challenge and exposure to cigarette smoke significantly worsened alcohol-related pancreatic injury, and this was associated with increased macrophage infiltration and induction of ER stress. The second aim of our study is to determine the effect of alcohol, smoking, and endotoxin on cultured stellate cell function, as well as interaction between stellate cells and the macrophages. We found that the smoke compounds and LPS significantly increase stellate cell migration, which is also a marker of stellate cell activation. And we also found that the cigarette smoke exposure and ethanol significantly reduce the stellate cell apoptosis. In terms of the macrophage and the stellate cell interactions, we measure the collagen expression in stellate cell cultured by themselves or co-cultured with bone marrow derived macrophages. And as shown on these slides, the expression of collagen by stellate cells has been increased by the co-culture with macrophages, suggesting macrophages induce stellate cell activation. To looking at the effect of stellate cells on macrophages, we cultured the bone marrow derived macrophage by itself or co-cultured with stellate cells. We then measure the CD206 as a marker of M2 polarization. And as shown on the slides, we can see that the stellate cells has significantly induced the CD206 by the macrophages, suggesting an M2 phenotype. And we know that interleukin-4 is one of the cytokines can polarize macrophages into M2. So we added an IL-4 blocking peptide in the culture system. And we can see there the expression of CD206 has been brought back to control level, which is suggesting IL-4 is one of the major mediators mediating this stellate cell-induced M2 polarization. In conclusion, alcohol, LPS, and the smoke increase the macrophage infiltration and the ER stress in the mouse model. Mouse stellate cells were activated by ethanol, smoke compounds, and LPS. Macrophages increase collagen mRNA expression of stellate cells. Stellate cell-induced polarization of macrophages to M2 phenotype, an effect likely mediated via interleukin-4. Our study implies that the smoke-related alcoholic acceleration of alcoholic pancreatitis may be mediated by stellate cell activation and the polarization of macrophages to a profibrogenic phenotype. Interleukin-4 is a potential therapeutic target to inhibit the progression of pancreatic injury. I'd like to thank my supervisor, Professor McNabb-Baltar, and the members of Pancreatic Research Group, as well as our international collaborators and the founding bodies. Thank you.
The paper is open for discussion.
Thank you for the talk. So in your model, what do you think the quantitative relationship is between macrophages and stellate cells? So how much is there of each cell type?
That's a very good question. And currently, we haven't directly compared the ratios of macrophages and stellate cells in the actual animal model, which we could have it done when we go back to lab. Thank you very much for your suggestion.
Hi, Stu Iceberg again from Columbia. I just had a question about the mouse model where you combine smoking and alcohol. So I think maybe I'm misremembering, but I think on some of the slides you were saying that this was a model of chronic pancreatitis. But did the combination of alcohol and smoking actually cause canonical features of chronic pancreatitis in the mice?
With the alcoholic pancreatitis model, we use the alcohol and the smoking, which is potentiate the LPS injury, but there will be always requiring a trigger factor to trigger the actual necroinflammation in the pancreas. So the LPS is
okay. So LPS was used to
is a trigger factor. And then in the human, we also found in the alcoholic pancreatitis patient, there's elevation of the circulating endotoxin level in the blood. That's why we're using the LPS as a trigger factor.
Thank you so much.
Thank you.
Our next presentation will be genetic factors behind the recurrence of pediatric pancreatitis, results from the APPLE-R, analysis of pediatric pancreatitis, prospective multicenter observational clinical study presented by Dr. Andrea Pornitzky of Semmelweis University. And Dr. Pornitzky is also recognized as a young investigator.
Thank you, dear colleagues. First, I would like to extend my thanks to the organizers of APA to give me the opportunity to present our study from our results from the APPLE study. As we all know, there is an increasing incidence in pediatric pancreatitis, mainly due to the better awareness of this disease. And thanks to the remarkable scientific effort and international collaborations and the growing body of the literature, more and more information available, but still a lot of questions need to be answered. To answer these questions, the Hungarian Pancreatic Study Group initiated an international multi-center observational trial called Apple, Analysis of Pediatric Pancreatitis, which has two parts. One of them is the retrospective database part, which incorporating those individuals who had acute, recurrent acute or chronic pancreatitis during childhood. And we questioned them according to the disease progression and also collecting blood samples to analyze the genetic backgrounds. And based on this data set, we hope to identify association between mutation and disease progression and etiology. The other part of the Apple trial is the prospective part, where we collected clinical data and focusing on the ongoing episode of acute pancreatitis. And the main reason of this part is to develop a specific scoring system with the severity on admission with pediatric pancreatitis. And we also collect blood samples on this part with the aim to analyze mutation and severity and complications. In this talk, I'm focusing on the Apple-R part. Until now, we have 164 cases with acute pancreatitis, 68 with acute acute pancreatitis, and 29 with chronic pancreatitis. Not surprisingly, patients with chronic pancreatitis are older at the diagnosis, and they were younger at the first acute episode due to the disease progression requires time. The acute pancreatitis patients, they were older at the first episode, but they had a shorter follow-up period, means that the first episode and the enrollment time are shorter. And this is a short limitation of our study regarding that they can be misclassified as an AP patient due to the time limitation. They can't proceed to chronic, acute recurrent or chronic pancreatitis. The pancreatic disease in family history significantly occurred more often in acute recurrent and chronic pancreatitis group. And it's mostly meant acute and chronic pancreatitis in the family history, but it should be pointed out that 14% of the CP patient had pancreatic cancer in the family history. The acute recurrent and chronic pancreatitis patient maintained diet more frequently. However, it is not recommended in any guidelines. According to the pancreatic family history, we calculated the acute, recurrent, and chronic pancreatitis rates and accompanying factors in different age, pediatric and adult age groups. For this analysis, we have used adult registry data to add it to the Apple data set. With the negative family history group shown in gray bars, they had a rate of idiopathic etiology, consistently in the 20 to 40%, while the positive family history group had an extent peak of idiopathic etiology peaking at 75% at 0 to 5 years of age, and steadily decreasing to meet the negative group in adulthood. We have found also a significant increase and emerging other factor like alcohol and smoking.
We're gonna continue with our next presentation. Thank you very much for that. And let's give her a round of applause.
So our next presentation is entitled Causes of Mortality After Total Pancreatectomy with Islet Cell Autotransplantation. Gregory Hooks from University of Minnesota will be presenting, and we'd like to acknowledge Gregory Hooks as a young investigator.
Right. So, hi, I'm Greg. I'm a fourth-year med student at the University of Minnesota, and I just want to extend my thanks to the APA so much for inviting me up here to speak to you all about mortality following TPIAT, or total pancreatectomy with islet auto transplantation, which I will be abbreviating as TPIAT going forward. Here are disclosures, and just for your reference, but none of them are relevant to the abstract being presented. So for TPIAT, I just want to remind everybody about the goals of surgery here. And the first goal when we remove the pancreas is to help treat the patient's pain. And even though it's very difficult to achieve full pain resolution, we do see significant pain improvement for up to 85% of those in our cohort. And the secondary goal too, with reintroduction of those islet cells into the portal system, is to improve the insulin needs over time. And up to 30% of our cohort is completely independent of their insulin. Unfortunately, these studies are performed over a pretty short duration. So what the university wanted to do was try to take a look at these longer term outcomes. So the TPIAT team decided to start the LIFT study this year to take a look at those long-term health outcomes, which includes risk factors for mortality and causes of death. So the goal of this abstract is to determine the survival, cause of death, and risk factors for mortality in patients undergoing TPIAT. The way we went about this was by reaching out to the National Death Index. We sent them the list of all 693 participants in our registry. They returned to us with 88 death certificates that included ICD-10 codes, which we were able to pair with each individual patient's EMR to determine if their death was associated with TPIAT or if it was independent. From there, we were able to extrapolate that data to find out what the risk factors for death are for this patient population. Just as a reference, this is what the data looked like as it was returned to us from the NDI. I want to highlight that the causes of death that we're taking a look at are in the green boxes. Those are the ICD-10 codes that we are using. Just to give you an idea of the patient population that we are taking a look at, the majority of our patients are female, and they tend to be a younger age with a duration of pancreatitis around 7 years. The majority of our patients are normal weight or overweight, with a few that are also underweight. And the majority of the patients fit into the genetic and idiopathic categories for pancreatitis etiology. Now, for the 88 death certificates that were returned to us, that makes up 12.7% of the whole cohort. But what I want to emphasize are the 5, 10, and 15-year survival rates. In particular, the 10-year survival rate for this population is about 86%, where in the literature, for chronic pancreatitis that does not undergo any type of surgery, they tend to have a survival rate closer to 70%. And if you take a look at this Kaplan-Meier curve, as expected, we see that older age tends to have higher risk for mortality. Now, moving on to kind of the bread and butter of the study is taking a look at what causes of death were related to TPIAT and which ones were independent. We wanted to categorize these things based on what we thought were directly associated with surgery, including infection, GI complications, and nutrition status, as well as things that were associated with diabetes. obviously diabetes complication being the leading cause there. But with some of the ICD-10 codes that were returned to us, a few of them included pancreatitis as the cause of death, which is pretty unlikely considering that they had their pancreas removed. So we tried to dig into their EMR to figure out if we could assign any specifics to their case, but unfortunately that wasn't always possible. So we conservatively put them in the TPIAT related group. And you can see the other more generalized causes of death in the unrelated category. Now, we put together an assessment of all of the risk factors that are associated with the patients who died. Interestingly, what we see for the protective factors are a longer duration of pancreatitis, as well as a more recent year of TPIAT, and a genetic etiology for their disease. The things that were increased risk for mortality included age at TPIAT, whether they were underweight or overweight. I also included fibrosis severity here, which is a quantitative measure assigned by the islet lab to specify the degree of fibrosis of the pancreas. I put that in here, even though it's statistically insignificant in the single variate model, but in the multivariate, you'll see that it becomes significant as a risk factor. I also put both of these forest plots in just to emphasize that the hazard ratios for overall mortality and those for TPIAT related mortality are very, very similar to each other. Now, one thing we really wanted to emphasize is how mortality has improved over time. We see that TPIAT, or a more recent TPIAT, is associated with higher rates of survival, especially when we adjust for the time of follow-up. It's not just that these patients haven't had the time to die, it's that they're actually getting a lot of the supports that they need. You can see that the change occurs at around 2007 to 2009, and that's pretty directly associated with the time at which the TPIAT program was able to expand at the university, offering multi-discipline care and longer-term follow-up, as well as nutrition coverage. So we see these rates continue to improve over time. And just to mention, I wanted to highlight some of the changes we see in the multivariate model, including the fibrosis severity, which becomes a risk factor or increased risk for mortality. And the genetic etiology is no longer considered to be protective. We think that's just due to compounding with the year or with the duration of pancreatitis and the age at TPIAT. So in conclusion, I just want to remind everybody that the 10-year survival for post-TPIAT is hovering at around 86%. And the risk factors that we're taking a close look at include age, the cause of pancreatitis, the duration of that pancreatitis, the patient's BMI, and the year in which that surgery was performed. Reassuringly, mortality is improving over time, and we think that will reinforce what patients need in terms of multidiscipline care and post-surgical follow-up with nutrition and just long-term care. And it will allow us to focus more on some of those preventable causes of death, including infection and nutritional status. I just want to mention my acknowledgements. Thank you to Dr. Bellin and the whole TPIAT team, as well as the NIDDK and funding sources. And ready for questions. Thank you.
The paper is open for questions. I just wanted to know, I'm not sure, maybe I missed it, but what was the average age of mortality?
The average age of mortality, I don't think I actually have the number off the top. I can dig into the data and if you provide your email, I can respond with that.
Yeah, because I'm curious, because we know that chronic pancreatitis in general patients will, have a shorter life expectancy. So it'd be interesting to see how it compares to, the more overall population.
Thank you very much indeed. That was a really good presentation, really interesting area to look at and to explore further. Just some comments maybe. One is that obviously the age and the fitness of the patients will be higher than the average total chronic pancreatitis patient population. So I think you should actually make that point when you emphasize the 86% 10-year survival rather than 70% in a previously described general chronic pancreatitis cohort, because I don't think that's fair otherwise to make that statement. Secondly, your classification of deaths. You've marked off some of the causes being related to the transplant, the chronic pancreatitis, etc., and the other causes you've identified as not being. I think you have to question the classification of those causes that are on the right-hand side as being separate from the disease that you're describing. Not that you haven't got it all right, but there's always a question because there are a lot of causes of death that chronic pancreatitis increases the risk of. And a question, please, you didn't address insulin independence or anything about the effect of the transplant in your exploration of causes or associated factors that could possibly explain death, where you did your univariate and multivariate analysis. Did you explore that at all?
So that was not actually included in that part of the study, partly because those were not things that were assessed in the cohort overall from the data that we've kind of accumulated over time.
That's a little bit surprising.
Well, some of those things are available and we're certainly going to try to expand,
Okay.
but in terms of the cause of death, some of the closer things that we were taking a look at that are harder to quantify and that kind of address your comments earlier are that we also had to associate it with the EMR. So some of those things like insulin dependence and just kind of the general health status of the patient towards the end of life is reinforced by the EMR. And we kind of use those things to help classify each patient really individually.
Great study, well done.
Yeah, thank you.
Thank you.
Thank you very much.
Our next presentation will be identification of early serum proteomic biomarkers that predict and suggest pathobiologic mechanisms of acute pancreatitis severity to advance precision medicine. Presented by Dr. Richard Waldron of Cedars-Sinai Medical Center.
Thank you. Thank you to the APA Selection Committee for putting our talk forward for presentation. And thank you all for attending this session. So medicine's come a long way in measuring features of patients' blood to determine their health status. You can see in the left panel sort of protein electrophoresis that just gives a few major bands, and it's diagnostic for multiple myeloma. On the right panel is the seminal first global proteomic studies that established the huge difference in concentration of different serum proteins. You can see on the left side, it's a log of 10 scale. So there are really less than 25 proteins that form the 99% of the serum proteins. And these are the normal serum proteins. Abnormal serum proteins include what we believe to leak from tissues and, of course, various cytokines and chemokines that are far lower concentrations. And we've heard a lot at this meeting about the key role that organ failure plays in mortality and severe acute pancreatitis. This curve just shows the existence of distinct phases of death, early and late, that depend on different features, but are both driven by organ failure and multiple organ failure. So it's important to have an early predictors to determine the severity of acute pancreatitis. So the advantages would be assigning appropriate level of care, timely organ support, and design of future clinical trials. So the real clinical hypothesis is that detection of serum biomarkers relevant to the pathogenesis of SAP will outperform conventional predictive parameters, that there are plenty of panels of biochemical measures that might help in this regard. And some of our longer term aims are shown below. in contrast, we have or complementary research hypothesis, which states that plasma proteomic signaling network signatures demarcate mild, moderate, and severe acute pancreatitis. So I've performed two small scale but relatively sensitive and deep proteomic investigations, which I call experiments 1 and 2. The first one features 10 samples from each of these categories: controls, mild, moderate, and severe severity levels. And the second has a bumped up numbers to 15 per condition. So it has a total of 60. The common feature is that all these samples were taken at the 48-hour time point. And in the experiment 1, I've not performed any abundant protein depletion because indeed abundant proteins may be highly significant to the health status. However, in the second experiment, I have depleted the abundant proteins, and that provides much greater proteomic depth. So it may double and triple the number of relevant proteins that are elevated or decreased. This simply shows that the samples were collected by Dr. Papachrisou's team, in fact, for the proof study. And the disease etiologies were dominated by gallstone acute pancreatitis. There was a good number of triglyceridemia related ones, very few ethanol or other etiologies. And I've made some updates to this table. It really matches the 15 patient experiment 2. You can see down the first column, they have pretty similar age ranges, not very uniform, a bit older in the severe cases. The sexes, they go back and forth. They're relatively well balanced, but then again, you have more males in the severe cases as well. In terms of BMI, there seemed to be a correlation. They are somewhat incrementally getting more obese with the severity. And that somewhat makes sense given that many of the cases are hypertriglyceridemic. It's not a very good mix of races. However, it is typical for Western Pennsylvania. So this is just a glance at the workflow of proteomic analysis. Of course, you take a blood, serum, or serum, in this case, sample, and prepare the samples for mass spec. You run through instrument, and then you take the data and process with software. So once you have this data, you can perform various bioinformatics, which I've done. So you take your intensity values determined for each protein. In the first experiment, I had 530 proteins identified, 221 of which I could quantify across the experiment because they're present in all the samples. We compared them by twofold comparisons, examined these by Venn, and looked at the gene ontology categories associated with each elevated or decreased proteins. And then we separate them really by whether they were associated with organ failure or not, because according to the Atlanta criteria, it's the severe and moderately severe cases that have some organ failure. So we associate the proteins that were found only in those cases with organ failure to just leverage that in our analysis. So indeed, we discovered that blood coagulation proteins and platelet degranulation proteins predominated in this analysis. And so therefore led us to believe that these are important processes in the severity of disease. This just shows the coagulation cascade, both extrinsic and intrinsic, and circled are 3 different proteins that were found elevated in the severe cases. And this is more network analysis. I'm not going to enumerate the details of the findings, but you can see certain transcription factors mediating signaling to a variety of processes, many of which affect immune cells. Overall, the severe disease tends to lead to possibility of organism death that we're aware. This is an overview of the hemostasis process and highlights a few of the important proteins that were observed: von Willebrand protein, fibrinogen, and of course processes such as fibrin clot formation and its regulation by PI1, leading to a sort of model that we express here as severe AP causes coagulopathy, and that leads to organ failure. Very simplistic. However, the new experimental data, it shows more deeper into the proteomes. So we're able to see many more of the proteins that result from cell lysis, which is believed to be associated with the early stages of pancreatitis. Just skipping ahead to this nice heat map of the new data performed by ANOVA. And so in this case, we have 1,400 proteins just detected. Each sample has around 600, 700, 800 proteins, but the overall experiment identifies 1,400 proteins. And indeed, I was able to perform subgroup analysis with 10 hypertriglyceridemia and 10 biliary samples. And this is it's a map, and it's a map of the gene ontology associated with elevated proteins in experiment 2. You can see that at the top in the lighter shaded circle, the acute phase response, that's very predominant. So proteins like C-reactive protein and SAA1 and 2 are there. But there are many others and quite a few others that are decreased. Those are diagrammed here, the gene ontology associated with these proteins. And one feature I just want to bring forward is there's definitely a balance between proteases and protease inhibitors. There's quite a number of both that are elevated. Please forgive the lighthearted nature of this slide, but it seems like Mortal Kombat out there. And I'd just like to thank my co-authors, the excellent proteomics core at Cedars-Sinai, and our funding agencies, as well as particularly Cedars-Sinai Precision Health, which has funded this work. Thank you very much.
Thank you. In the interest of time, I think we're going to move on to the next presentation. Thank you very much.
All right, so our next presentation is entitled A Procalcitonin-Based Algorithm to Guide Antibiotic Use in Patients with Acute Pancreatitis, the ProCap Randomized Control Trial. The presentation is by Dr. Siwa Randerna from University of Manchester. Thank you so much.
Thank you. So, chairs, ladies and gentlemen, I'd like to start by thanking the APA for allowing us to share these data. And actually, I'd also like to thank the chair for checking on the welfare of our earlier speaker, because if we're a family, we look after each other. This is my disclosure slide. International guidelines recommend against the use of antibiotics in acute pancreatitis in the absence of a specific infection. However, we know that globally, there's overuse of antibiotics in all forms of acute pancreatitis and at all stages because of the difficulty in distinguishing between a systemic inflammatory response and infection. Procalcitonin is the peptide precursor of calcitonin and is produced in response to infection. Normal physiologic levels are very low, rise rapidly in response to infection, and fall equally rapidly after eradication of infection. Procalcitonin measurement-based algorithms have been evaluated in a range of disease settings. And this study aims to test the hypothesis that a procalcitonin-based algorithm to guide initiation, continuation, and discontinuation of antibiotics will lead to reduced antibiotic use in patients with acute pancreatitis without an adverse effect on outcome. ProCap is a patient-blinded, single-center, randomized control trial with the intervention being a procalcitonin measurement-based algorithm. Inclusion criteria were adult patients over the age of 18 years able to give informed consent, and 2 out of 3 of the standard Atlanta 2012 criteria. Important exclusion criteria included those patients who were unable to give informed consent and patients with comorbidities which mandated prolonged antibiotic therapy. This table shows the intervention arm compared to the control arm, and you can see that the standard care was the same for all other aspects of acute pancreatitis. You can also see that mandated antibiotic use, for example, for treatment of specific infections or for prophylaxis of interventional procedures, was the same in both arms of the study. It has to be for safety. So the only difference is that when there are situations where people are contemplating empiric antibiotic use, we ask that clinicians use a procalcitonin measurement-based algorithm. And this is the chart which was placed in the notes. I don't think it projects well, but basically if it's less than 1 microgram per liter, we'd say do not start antibiotics. If it's more than 1 microgram per liter, we'd say start antibiotics. If it's less than 1 and clinicians were still concerned about potential for infection, they could repeat the assay at 24 hours. So participants were randomly assigned on a 1-to-1 basis to intervention and control. To try and ensure similarity in the populations, we had 2 stratification variables. 1, disease severity, mild against moderate and severe. And second, admission pathway. Those patients admitted directly to the hospital through our own emergency room versus those patients who were tertiary transfers with complex pancreatitis typically for endoscopic intervention later in the disease. Applying a superiority design, of course, the null hypothesis then is that antibiotic use has no effect. We know that about 60% of patients admitted to hospital with acute pancreatitis will receive antibiotics, and a 20% absolute reduction, although ambitious, was thought to be both feasible and clinically relevant, and this required 260 patients, 130 in each arm, to show this difference with 90% power, and also provide a 5.8% non-inferiority margin. I'd like you to focus just on the primary outcome, which is the very simple binary outcome. Were patients exposed to antibiotics, yes or no, during the index stay? There's a whole series of secondary outcomes, which is typical for this kind of study. The study was approved by a National Research Ethics Committee, prospectively registered with ISRCTN, and the protocol was published prior to commencement of recruitment. ProCap opened to recruitment on the 29th of July 2018 and ran to the 13th of November 2020. I put that in just to emphasize that we continued recruitment through the COVID pandemic because we were regarded as an acute phase trial. I'm going to focus on our results. So 369 patients were assessed for eligibility. 132 were randomized to the intervention arm, 128 to the control arm. All of these patients' results were available in the final analysis. If we look at the baseline characteristics, you can see that there's no difference between intervention and control in terms of age, gender, severity of acute pancreatitis, and tertiary and primary admission. There's also no difference between admission organ dysfunction and etiology. This slide is the key result. And you can see that ProCap met its primary endpoint. The use of a procalcitonin algorithm resulted in a significant reduction in antibiotic use, and this significance persisted once mandated prophylactic antibiotic use was excluded. This translated into a 1-day reduction in total days of antibiotic use, which is also statistically significant. There was no difference in mortality, clinical infection, hospital-acquired infection, length of stay, or cost of stay. This forest plot allows a little bit of exploration of the subsidiary points, and you can see that there's no difference between mild and severe disease. The intervention arm was still significant there, and similar in between patients who were primary admissions and tertiary transfers. Adverse events were low in both arms of the study, with less than 10% of patients having adverse events. And the important point to emphasize here is that none of these adverse events in the intervention arm were related to avoidance of antibiotics. Lastly, if we look at the intervention fidelity, you can see that the decision to have no antibiotics was typically associated with a procalcitonin level of less than 1, as was the decision to stop antibiotics. So in conclusion, our findings suggest that procalcitonin guided care can reduce antibiotic use without increasing infection or harm in patients with acute pancreatitis. Procalcitonin-based algorithms to guide antibiotic use should be considered for care in this group of patients and be incorporated into future guidelines on the management of acute pancreatitis. The paper was published a couple of months back in Lancet Gastroenterology. I'd like to thank all of the team who undertook the study. I'd like to thank the patients for participating in the study and you all for your attention. Thank you very much.
So the paper is open for discussion. I wonder, but did you have any of your patients that had infected necrosis?
Yes, there was a small number of patients in the study, in this kind of study, who had infected necrosis in both arms of the study. Many of those patients with infection had antibiotics, and they correctly had antibiotics. So the effect of the PCT algorithm in terms of avoiding antibiotics once you have infected necrosis is relatively small.
Mm-hmm.
Greg Beelman, Minneapolis. Thanks for doing this really important study, because at least in my institution, it seems like the automatic reflex anytime somebody has SIRS is to put them on months of broad spectrum antibiotics. Did you look at any of the other secondary things like cost of antibiotics or kilograms of cephalosporins used or anything like that? Thank you for doing this study.
Thank you, Greg. Those are great questions. So I think what this study does is that helps in litigious healthcare systems like yours and ours, that if the resident measures the procalcitonin and the result is less than 1, it gives you some kind of support for saying, look, there's a decision why I didn't use antibiotics. We did look at some of those things. They're in the full manuscript.
And the other thing that'd be interesting is to see if that leads also to less C. diff colitis, because you're using less antibiotics too.
Yes, I was hoping that it would, but actually the C. diff colitis rate is not different between the intervention and the control, but that's because it's relatively low in both.
All right, thank you so much.
Thank you.
So I'd like to thank everyone for your attention and your engagement during this session. We do have one ask, is that please remain for the, we'd like to invite back Dr. Parniski to complete her presentation on genetic factors behind the recurrence of pediatric pancreatitis. Dr. Parniski, welcome back.
Thank you, and sorry for the interruption. So when I stopped as somewhere that according to the presence of pancreatic family history, we evaluated acute, recurrent, and chronic pancreatitis rates and accompanying factors in different pediatric and adult age group. And for this analysis, we used adult registry data added to the Apple data set. While the negative family history that's indicated with gray bars had a rate of idiopathic etiology consistently in the 20 to 40% range, the positive group were indicated with green had an excess of idiopathic AP in the pediatric age group, peaking at 75% at 0 to 5 years age, then steadily decreasing to meet the negative group in adulthood. This is likely due to genetic risk factor being responsible for familial aggregation among pediatric patients, especially in early childhood. However, next to decline in idiopathic etiology, other factor emerged at 12 to 17 years. We found significantly higher rate of alcohol consumption and or smoking in patients with positive family history, this indicated with blue bars. So positive family history not only means inheriting predisposing genes, but also harmful addictions, which also can increase the possibility of acute recurrence episodes and chronic pancreatitis. So the genetic results of this part of the study. So we already have 261 patients, and almost 80% of them completed the genetic testing. And we have found almost half of them at least one pathogenic mutation. This graph represents the breakdown of the found known genetic predisposing mutations. And the size of the circles represents the number of the patients. We divided those ones who have positive genetic results into the etiological groups. And what I would like to point out here is that there is an overrepresentation of PRSS1 mutation in the idiopathic group. So this patient population have their correct diagnosis as hereditary pancreatitis, so we can help the family to understand better the children's disease. The other one is the overrepresentation of CPA1 and in the groups with anatomic malformation, and the CFTR variants overrepresented in the group with traumatic injuries. When we look into the etiological factor or risk factors in the whole data set of APPLE, or the whole patient population of the APPLE trial, that you can see that those ones with one episode of biliary pancreatitis was the most common, followed by the genetic part, and then the genetic background rose up to 50% in the acute recurrent group and 55% to the chronic pancreatitis group. Here you can see the distribution of genetic alteration according to the disease progression. We found significant intergroup differences with PRSS1 and SPINK1, and a similar tendency in CTRC. And there is, so those patients who have more than one mutation, they were mostly chronic pancreatitis patients. The cumulative genetic risk calculation also was aligned with the above mentioned data, but how does this cumulative genetic risk associated with the disease onset and progression is still a question. So to conclude, the positive family history of pancreatic diseases occurred more often in children with acute recurrent and chronic pancreatitis, and closer follow-up for this patient population incorporating alcohol and smoking prevention or cessation program should be considered. Regardless of the etiology, more than half of the children with pancreatitis have genetic predisposing factors. CTRC mutation occurred more frequently in our data set, and follow-up studies are needed to answer those questions, how these genetic factors affect on the disease course and the progression. That's why we created the APPLE-F trial to answer these questions. So hopefully next year I can present the data of that one as well. Thank you for your attention, and thanks to my colleagues for their help.
Thank you very much for that presentation. And I want to give you full credit for extraordinary performance. Very, very well done to come back from that. One can get very nervous. I've been very nervous, and sometimes it can be very impactful, but you did extremely well. So please don't worry and take it away and think, oh, because we've all done silly things. And I can assure you I have, and you have to somehow carry on.
Thank you.
So I wonder if I could ask you, please, firstly, very interesting presentation, extremely valuable information and unique registry that has been created. And the retrospective study that you've done is very informative. And what's interesting is that you have so many CTLC mutations, and yet we have large series which suggest that there are other mutations that are actually significantly more common, but unfortunately they've been selected in very, very special circumstances, collecting specimens and then examining them in particular ways for particular genetic mutations. What do you think in future with your registry you would be hoping to show? How many patients do you think you will be able to collect data on? And do you think that you will show the same pattern of genetic mutations?
So hopefully we can continue the data collection with new cases of acute pancreatitis and then follow them up, because now we really know that this is necessary to see how the disease going on and to correlate this with the genetic results. And we have several discussions with Miklos about the CDRC, and it's also really interesting for us how whether is there an effect on the disease course really as much as we believe, or it's
well, I suppose with any
the balance.
Pardon?
Where is the balance between
Yes.
genetics and
I suppose with any prospective series that is yet to be done, you just got to wait and see the results. And part of the reason for asking the question about that was, is there anything that you're aware of in the method of collecting the data retrospectively that might be different prospectively? I guess maybe the prospective data will be cleaner because you're not collecting right back.
Yes. So we have missing data in the retrospective set.
Sorry. Yeah.
So wish we would be Benjamin Button and.
Andy, I want to thank you because I listened to the first half of your presentation. I got a phone call, had to step out. So I completely missed the second half. And it was really thank you for completing it. So it's more like a comment. So this type of analysis has been attempted by other groups, and the Inspire published papers, I think, like this. And I think what's really clear, it's very difficult to do this because there's many genes and different impacts, and there's many mutations, different frequencies, even within a gene. When you say a CTRC mutation, different mutations have different impacts. So I think we have, as a field, we have to sort of think about it, how we define these things so we can come up with scores or descriptors that we can then relate to the phenotype somehow. But I think it's a good effort, and to do this at this stage. Thank you.
Thank you, Miklos. And that's why we start calculating the cumulative risk and try to figure out how we can provide the scoring system based on the genetics and the etiological factors, adding the age and the gender and so on. Just we have a robust data set.
Andrea, wonderful talk, as always. And I wanted to say that I think prospective studies will be helpful because you do everything the same moving forward, whereas retrospectively, things may have been performed differently, and those can lead to various bias confounding. But the question I had for you was, what really piqued my interest was that the biliary pancreatitis patients, and I think for mostly the acute pancreatitis, because most of them were biliary, right, had genetic etiologies identified in something like 30%, or if I saw that correctly, and it was a diversity of genetic variants that were different from the other etiologies. The question is, whether biliary pancreatitis in and of itself is the only causative risk factor for the emergence of pancreatitis. And I say this because traditionally we think if the gallstone gets stuck in the distal common bile duct, they will develop pancreatitis. But how many of us have serendipitously seen choledocholithiasis, and they never developed pancreatitis. And you probably miss it quite a bit, and they're passing a lot of stones, but something else triggers it, and maybe it's a genetic risk factor. So I thought I'd ask you about that. But then on the other hand, it could also be your control. So if you don't have a control population, would you just comment on whether those genetic etiologies are more like the background for a control population, or are they truly increased in the biliary?
Biliary pancreatitis is always, I think, an interesting part of pediatric pancreatitis, and maybe the answer or the hint of the first part of your question is that the multiple hits and multiple targets. So we do not exactly know what was first, the chicken or the egg, and yes, you are right. We should incorporate a kind of a control group to compare and understand better this situation.
Thank you.
Right, I probably should ask the last question because there's a session that starts here in like 14 minutes. And Andrea, great comeback, great study. I'm very, very proud of you. You've done a wonderful job. So great study. My question is what are the mutations with the CTRC? Because there's one mutation, G60G, that we see a lot in INSPIRE cohorts. Is that what you see?
Yes.
Okay.
Yes, we have some rare CTRC variants as well in 2 or 3 cases, but mostly dear G60G.
Okay. And answer to Miklos, who has since left, it
He
looks
has
like.
a phone call.
Another phone call.
Another.
Okay. So actually INSPIRE is doing the genetic testing. Finally, the problem was the funding. So as we find more funding, we're hopefully we will be able to answer this question globally. But thank you.
Thank you.
I just wanted to make one last comment, which was really, I think, helpful because you showed that in the older age spectrum of your cohort, that the smoking, the alcohol, and that was a heated debate earlier about the role genetics plays, and your information helps us. And as adult gastroenterologists, we see younger individuals who develop recurrent acute pancreatitis, chronic pancreatitis. So your data is very helpful in us addressing that question, how we think about it. Let's give a round of applause. Thank you so much. In fact, thank you all for your attention, for staying. I know we ran over, but appreciate your engagement, and we'll close the session.